It is now my pleasure to introduce my summit co-chair, Dr. Cheryl King, who will introduce our next speaker. Dr. King is a professor in the Department of Psychiatry and Psychology and the director of Youth and Young Adult Depression and Suicide Prevention Research in the Department of Psychiatry at the University of Michigan Medical School. Dr. King also serves as the suicide content lead for the U of M Injury Prevention Center, where she provides expertise regarding the risk of suicide. And she is a clinical scientist who studies interventions and public health approaches to optimize youth screening strategies, risk assessments, and psychological interventions for both individuals and high-risk groups. On a personal note, I could say that I've worked with Cheryl for over a decade, and she's been a wonderful mentor and collaborator, and it's really a great pleasure for me to be able to introduce her. So Dr. Cheryl King.
Thank you, Dr. Ilgen Mark. Thanks very much. Now it's my pleasure to introduce Dr. Jane Pearson, who's going to speak about NIMH suicide prevention research priorities. As Governor Whitmer said earlier, we all have a role to play, and it's more than fair to say that Dr. Pearson has had an outsized role for many years. She has positively influenced strategic thinking about directions in suicide prevention research, and she has facilitated strong transdisciplinary collaborations in thinking and suicide prevention science. Dr. Pearson is the special advisor to the director of the National Institute of Mental Health on suicide research. She leads the NIMH suicide research team, overseeing the development of suicide research initiatives. Dr. Pearson assisted in the development of the first and the second U.S. Surgeon General's call to action to prevent suicide. She led the development of the National Action Alliance for Suicide Prevention's prioritized research agenda. She is an adjunct associate professor at Johns Hopkins University and a fellow of the American Psychological Association, and has authored important papers on suicide research needs and the ethical challenges in suicide research. We are very glad she's joined us today. And before we turn to her presentation, just a reminder, we pre-recorded all the plenary sessions to limit any technical difficulties we may have, but the presenters and Dr. Pearson will take questions after their talks, and they'll be answering these questions in real time live. Please do type any questions you have in the Q&A box, and I'll pose these questions, as many as possible, to Dr. Pearson after her presentation. Now, please join me in welcoming Dr. Jane Pearson.
Thank you, Cheryl. It's great to be a part of this really important summit. Thanks for the invitation. I have no conflicts to disclose. And here's an overview of the overview. There'll be a lot of great speakers at this conference talking about some of these topics in depth, but I wanted to walk through some of these because they're really important in terms of how we're prioritizing research at NIMH. So we all heard the good news, I think, that in 2019, the suicide rates did go down. It's still the 10th leading cause of death, but this drop is still important because of how life expectancy had been dropping. However, as we'll again talk about the 2020 numbers, life expectancy due to COVID certainly will be dropping. So we will see how all of this plays out, but let's think about what happened in 2019 and what we can learn from it. So this is from the CDC that published these results on February 19th, and they've been busy getting out 2019 data. As we all know, most of the deaths, are males in the US, the majority. Here's the total rate, and here you can see the drop. For females, and we're looking at age groups here now, we can see that, the drops are from these middle 25 up to 64, up to 74 group. drops that had been pushing the increases over time. But the 75 and older, the limited number of women there, a little bit of uptick. And for younger girls, for the 10 to 14-year-olds, we're worried about this trend. And we'll be talking a little bit more about this. If you look at just males, the 75 and older kind of holding steady, sort of a trend going up to 2019. But we see these drops here in the large numbers of suicide among males. And again, an uptick down here for the younger males, dropping off, but also for the 15 to 24-year-olds. So again, where youth had been dropping previously, or at least staying pretty stable, we're seeing these increases. That initial report from CDC in mid-February also looked at methods. And as we all know, addressing methods in suicide would be probably the most efficient way to reduce suicide deaths. So it's important to look at some of these trends. So this is for female suicides, trends from 1999 to 2019. So we can see that poisoning, which had been one of the most frequent type of method for women, starting to drop in the last 5 or so years, and then leveling out, with firearms coming up a bit, but in the last 2018 to 2019 dropping. And we don't know what's going on here with the poisoning part. And it might be that you've got experts there at your injury center who could be taking a look at what type of poisoning is involved here to understand what that is. This increase in firearms here, but then drop, could be promising. Suffocation, of course, is very difficult to prevent. So seeing any increase in that tells us we have to get further upstream in terms of our interventions. No surprise here in terms of looking at methods for males that firearms are the number one. There was another report from CDC just last week breaking out the 2018 to 2019 numbers, and firearms continued to be high among rural areas. So that's still an important group to consider and hard to reach. We might not be able to reach them through healthcare. So firearms remain a huge challenge. Some increase in suffocation, but very limited numbers in terms of the percent of suicides that are by poisoning for males. Now, that was the good news in terms of overall rate going down. What we did want to do as soon as we heard about those results decreasing in 2019, Rajiv Ramchand, who's working with us half-time at NIMH, started looking through the data to see which racial and ethnic groups benefited from the decrease, basically. So the black line here is the total rate, dropping to 13.9 per 100,000. The line for whites at 15.7. So that was also a drop. So we've got the benefit there for white Americans, some benefit for American Indians, Alaska Natives, that's the orange line here. But under this red circle, we can see that the increase for Black Americans and Asian Pacific Islanders is going against the total. And this trend, if you will, has been happening, particularly for Black Americans, for some time. So we have work to do there. And I've mentioned youth a couple times. And a number of you, I think, are involved with some of our efforts, starting to look at very young kids in terms of suicide deaths. This table looks at how many kids ages 5 to 12 died by suicide starting in 2018. At that point, there were 49 deaths. If we go to 2013, almost double, 102 deaths. If we go to 2018, we're up to 185 deaths. But we're also very aware that these are still quite small numbers. These are national numbers. If we start moving to 13 to 17-year-olds, now we're like tenfold. So yes, this is a concerning trend, but it's also very difficult to study because of these small numbers. The HHS folks did a response, HHS meaning NIH, NIMH, NICHD, CDC, SAMHSA. All of us were asked to respond to this Congressional Black Caucus report on suicide. And that was posted December 2019. And our report, which I think we're getting ready to post on the NIMH website so you can take a look at it, we decided to drill down to see what those actual numbers were for Black youth and all children. So again, this is just illustrating those small numbers, but also like breaking out for Black children. So if we think about the ages 5 to 9 and look across these years, the circle's kind of focusing in on this more recent trend. You can see typically what's suppressed when there's less than 20 cases, those numbers don't show up. When you're doing, I think it's whiskers, you can see how small some of these numbers, and even in 2010, there were no, for example, Black children who died by suicide in 2010, and certainly under 5 here. But they're an interesting proportion of all kids died by suicide. If you increase that age window to 11, from 5 to 11, you can start seeing some of these numbers going up in terms of their actual frequency. And then also this trend where you're almost doubling like what it was in 2011 up to 2017. Again, very small numbers, but going in a direction we don't want to see. Finally, 5 to 12-year-olds. If we open it up to 12-year-olds, again, now you can see these numbers doubling for all children in terms of suicide deaths. But again, over time, these numbers are going up. If we think about, what we're worried about over time, not just suicide deaths, but also attempts and ideation, this is a combination of the NISDA, National Survey on Drug Use and Health, combining the 2018 and 2019 years. So thoughts of suicide in the last year, 4% made a suicide plan and attempted suicide. And I'm sure you're used to seeing these numbers. If we think about this, though, with high school students for younger people, these numbers, percentages are much higher. Again, these are thoughts in the past year, and certainly much higher numbers for kids reporting attempts. There's a lot of information on YRBS, and hopefully there's other presentations going through this. Michael Lindsay has a really important paper looking at trends since 91, looking at Black youth increases. We could also think about how to look at trends over time by looking at hospital admissions. And this paper includes 31 children's hospitals. And we're looking at 2008 here through 2015, broken out by age groups. And again, this gave us a bit of a window on really young kids. If you think about these it's the percent of all encounters. So not a lot of encounters for young kids. And among those, how many are suicide ideation attempts, what percent? So for the 5 to 11-year-olds, and this is a little bit before the uptick that we saw in the deaths, there's still a bit of an increase, but the trends here for 12 to 14-year-olds and 15 to 17-year-olds has been growing over time in terms of more encounters in hospitals. And some of you might be familiar with this study. This is not going to be a national sample, but it's sizable. It's 11,000 kids in the Adolescent Brain Cognitive Development Study, or ABCD. And you may have seen several publications that came out on their baseline data. And it was quite striking to us to see the percentages here. These are, I believe, Kitty Sad's lifetime estimates. So 6% reporting passive ideation and 4% lifetime. So lifetime of a 9 to 10-year-old reporting active ideation. Over 1% reporting an attempt already, and a rather high percentage here for non-suicidal self-injury. Many of these kids were selected to be in the cohort with externalizing behaviors as a at-risk group for substance use. But still, this is more than I think many of us thought we would find. So I mentioned we're going to be looking at trends, and I'm sure some of you have been hearing about this opportunity to look at quarterly reports that CDC puts out. So the drop, you can just go to this website, plug in the type of death, put in age adjustment, and the 3-month period where we started to see this drop in the last quarter of 2019. And going back, if you do the 12-month averaging, so far holding into the first quarter of 2020 in terms of that data. Of course, that's just getting close right up to COVID, so we don't know what we're going to find. But knowing about this resource, I think, is going to be really helpful for us to see what had happened. I do want to mention 2 reports from states. Now, we have to put the right amount of caution on this because these are very short time windows. This is looking at suicides under COVID. I'll talk through the Maryland numbers here first. So this was from researchers at the School of Public Health at Hopkins, working with the Maryland Medical Examiner, looking at this window, initial lockdowns through May. And what they did was compare it to years prior. So 2020 versus 2018, 2017, and the percent change. So I think many of us were relieved to hear that suicide rates had gone down under COVID, but I think people were beginning to report Cook County in Illinois was getting concerned about increases in more Black decedents. So yes, there was a decrease in white suicides, increase in Blacks in Maryland under that time period. And similarly, this report from Connecticut, same kind of pattern. This is not averaging across time, but looking at the 2020, the non-whites in Connecticut, who had been lower, except for 2015, about the same, here are showing a higher rate. Again, very small numbers. We don't know what this is going to look like if you continue to stretch this out over time, but certainly concerning. So we'll be watching for this and seeing what's happening. And I'm sure many of you heard about this report. It's been difficult to get national surveys out under COVID, and this interesting study with CDC and researchers from Australia were able to do a panel using Qualtrics, I think, looking at how people were experiencing the pandemic. And the big outcome that came from this that got a lot of news coverage was that underserved populations were under more stress. Unpaid caregivers were having much more difficulties. And this elevated suicide in the last 30 days of 11%, of course, was very concerning too. So one of the things we've talked about at NIMH is that we have to keep working on things we know could help people. So we have to stick with what we know in addition to understanding some of these projections. So I'll just go through a couple highlights here in terms of trying to do something about these suicide rates. So you may have seen this, we call it our bubble slide, where we try to think about, okay, who's died in the US? Where were they seen before they died? What kind of methods? What are our opportunities to do better identification and intervention? So if we try to keep this updated the best we can, we're using 2019 data. So about half of those deaths were by firearms. About half are 50 and older. We can think about who's accessed healthcare in the last 30 days or even the last year. This was in the emergency departments in the last year. And it's important to think about if, for example, if we saw a veteran, the 6,000 of these deaths projected, or if we were able to enact one of the policies on firearm safety, could we have reached them? Were they in the emergency department? Had they been incarcerated? All of these seem to be opportunities to us to try to address people's risk and give them support and intervention. So this is just going over some of the numbers again in terms of what we know from the Mental Health Research Network's examination of who died by suicide, who had been in healthcare, and what was that timing like and pattern like. So almost 90% of that MHRN sample who died by suicide had been seen in care. The ED in the past year, the ED is, the numbers are different, but if you think about how focused an ED is in terms of what their job is to figure out who's at risk for what in a hurry, these are really important numbers to think about, where in like just under half are seen in the ED in the year of a suicide death. So we still see those as very important opportunities. And you'll be hearing from other speakers at this conference about zero suicide, but this is just to emphasize that there's been a lot of work going on this. There are recommended standards of care, and there's many opportunities where people can basically fall through the cracks. But there's also more and more information about what can be done to make that bridge a bit stronger, to make sure nobody's falling through the cracks and they get the care that they need. So I'm sure you've seen this slide more than once, work by Ed Boudreau in the EdSafe study, looking at 8 different emergency departments, looking over time, how much screening was going on without just naturally as treatment as usual when universal screening was implemented. And then the study also included a brief intervention. This is looking at the screening during that intervention time. The bottom line is that you can double the number of people detected at risk by using universal screening. And the study using the ASQ, the Ask Suicide Screening Question by Lisa Horowitz at NIMH, found similar findings in a pediatric setting in Baltimore. So if they were comparing, if you just use the ASQ suicide screen with kids with behavioral health versus universally, if you used it universally, again, you could double the number of kids identified at risk. And this was really important for males and Black males in particular. So I don't have to say an awful lot about this study because you're co-chairs of the meeting. Cheryl King has been working on this for years with quite a team of folks and the PCARE network. So I'm just going to mention this briefly. But the EdSTARS study that used a computerized adaptive screen basically, picked up on the ASQ and then added a lot of other questions to determine what else could help predict risk in kids, in 12 to 17-year-olds. There's another study to, again, test that same algorithm. And you get really very reasonable sensitivity and specificity when it's set at 80% to exceed that here. And the good news here is that it's doable, it's brief, it's under 2 minutes, and you can also adjust the sensitivity and specificity, which possibly gives you more options than a straight ASQ. But each could have their own strengths, and the good news is they both work pretty well. You'll also be hearing about risk algorithms at the meeting, so I'm not going to spend a lot of time, but the point here is that you can use medical record data, you can identify people at different strata of risk, and you can use that information in an actionable way. So I think you're going to be hearing more about how that happens in the VA. And again, in the Mental Health Research Network, this is being used. I'm not sure to what degree, and maybe Brian Amadani can tell you more about that, But the good news is it's there and clinicians are finding it useful. We do have a bit more work to do on underserved populations because you have to have data in there about people to be able to predict something about them. We do have tools in the toolbox that seem to work. So this is a review by Stephanie Dupnick looking at brief interventions. This includes a lot of studies here that you'll be familiar with, a number from the ED. This is more about brief interventions, safety planning, follow-up right after an attempt. So these all look quite hopeful. A few favoring the control group, but mostly showing benefit. Folks here at the University of Michigan did take a look at what we know about youth suicide risk. This was published last year, and we have more work to do here. So there was not a lot kind of blowing out from TAU in terms of really strong effects. Was that because TAU was getting better under these circumstances? It's still hard to reach males and underserved youth. We need more studies focused on those samples in particular. There wasn't a lot on kids under 12. And there's a lot of opportunities to talk about learning more about trajectories and technical technologies that could be applied to improving both monitoring, trajectory, characterization, and outreach through the interventions. So I did want to mention this quickly about the ED, especially under COVID, where a lot of mental health got switched to telehealth. We did feel like it was really important to help ED providers have some telehealth assistance. This happens with stroke patients who come into the ED. They can quickly consult with neurologists. What would happen if they were able to consult more with behavioral health folks? So there was an RFA for this. Ed Boudreau is funded from the first round. We just finished a second round of review. So stay tuned on that one. I also wanted to mention that we're trying to build tools in the toolbox for rapid acting interventions. I'll just go through this quickly, but we had known about, ketamine being rapid acting for depression, treatment-resistant depression, and we were suspecting in ketamine clinics that people were going there who had suicide risk. So it's important to understand safety, dosing, and what should follow after some of these initial fast-acting interventions start, because we're pretty certain people need skills to manage whatever got them into the suicidal risk. So this is just to say that we have a mix of studies now using ketamine or esketamine on youth starting, adults, different settings, and we also have some neuromodulation interventions that are being tried with both youth and adults, outpatient and inpatient. So we're pretty excited about all of these starting. We hope many of these will turn into larger clinical trials and really give us more tools that we can use. And just a few words about trajectories and intervention approaches. So I mentioned the Congressional Black Caucuses report that came out in December called Ring the Alarm. So we've been trying to go through our portfolio, trying to understand what we have, what we've got missing. This is a notice of special interest that I hope many of you will take a look at and think about. And we went through our whole range of science in terms of trying to understand what we know and what we need to know to address this problem. In terms of technologies, these are just two examples. We've got a growing small business portfolio that's also looking at a lot of technology in mental health and suicide risk. So that's great. This is just highlighting work by Kleiman, Glenn, and Lou, where you can start looking at kids' trajectories in terms of real-time monitoring up to a distress point. And that would suggest a way of trying to catch kids at their risk instead of hearing about it a week later in the therapy session. Dr. Seitz has also done this here at University of Michigan and shown that this is a feasible thing to ping kids after they've been in the hospital, checking on how they're doing, and a way of tracking, which starts building up a great opportunity for just-in-time interventions, which is what this is an illustration of. So this was Evan Kleiman working with adult psychiatric inpatients, assessing both their challenges in terms of cognitive flexibility, emotional regulation, and mindfulness, and then trying to match those measures with needed interventions in time. So he figured 3 days, adult inpatient stays, this should work. And of course, that doesn't always work. Either you can't get to somebody in time, or they're discharged in a way that you didn't expect. Anyway, so he's trying to work on this with telehealth and trying to teach people how to use these interventions through telehealth. So again, with this R34, a lot to explore, and we're hopeful that that would be also another way to reach people and leverage the number of limited behavioral health specialists we have. Hopefully you all know about our suicide centers announcement, which could include all of those things we've been describing. The important part of this is to understand that we're trying to get centers to think about where we could have some really high impact near term. So these are a little less translational in the sense of we want to see applicants thinking about where they could be within a system of care, within a boundaried population, and think through what could be improved quickly. So we have some applications in now. The next application due date is in May. And I just want to mention a few things about trajectories and earlier interventions. We have to start sooner. We have to diversify our portfolio. We've been very focused on the high-risk people because we felt like we needed to know what to do with people who are referred to healthcare and so on. But many people have said, why are we waiting to intervene until now? Well, we're not waiting. We're trying to get all of our tools lined up. And we've known for some time that through this good behavior game protocol that had suicide added as a supplement to understand if there were benefits in high school, that the good behavior game was much safer protecting against reports of ideation over the standard setting for both males and females. We've got many others that we can think about. And Eve Rader and Belinda Sims, my colleagues at NIMH, have been thinking about this for some time and have organized a number of different symposia and encouraging researchers to be thinking about what they can analyze. So there's plenty of theory, there's plenty of mechanisms that have been identified, and schools, this is going to be one of the places where we field this work, are asking what are effective interventions that address multiple risk factors. So we have the opportunity right now because of COVID and so many schools worried about kids' mental health. I think we've got a great opportunity to be thinking about school systems. So quick summary. Great that 2019 rates went down, but that wasn't a benefit for all Americans. So we have to think about how we're going to address those groups better. And we're still very worried about increasing rates among youth. You're going to hear more about COVID from other speakers, but the initial work that was coming out, at least around some windows between March and May, are very worrisome. We made a lot of progress in risk identification, interventions, but we need to measure our outcomes. And we always have to measure outcomes for suicide attempts and deaths, but now we can also think about measuring outcomes to address health equity. We have to know when our interventions are not working for some of the population, and this should be a way to help us track that. And then finally, I just mentioned opportunities for upstream intervention. These will have to be interventions that we invest in over time, but we know we need to do this. So that's it, and I look forward to questions.
So thank you very much, Dr. Pearson, for that rich presentation and for all your work in suicide prevention in facilitating our research. We do have time for some questions. I believe we have about 5 minutes for questions. Quite a number have come in. Some of these are really referring to the suicide rate. And let me just start with one of those. What are your thoughts? Could the increase in suicide rates that we've seen over the years, not this last year, but over a number of years, could they be accounted for by reporting or data collection efforts rather than by an actual increase in the risk of suicide?
It's a great question, and it comes up from time to time. It's good that greater awareness around suicide is helping us identify more people. Does it really affect coroners, medical examiners? It would take a particular type of study to start taking a look at how that works. But we do know it really depends on the medical examiner and the coroner. And you can actually see a shift in a state if the medical examiner changes and has a different threshold. So it's possible, but I think overall, the trends are probably quite real. We also know some of the medical examiners and coroners are hesitant about labeling a child death a suicide death too. So you can even think about it for subgroups if they're having differences of opinions or they're less comfortable making that adjudication. But I would say overall, I think that trend, unfortunately, was real of increasing rates over time. So there are other ways of looking at that. And if the person has more questions, we can certainly refer them to other experts who look at medical examiner determinations.
Okay, turning to a different topic, what does NIMH see as opportunities for improving our interventions for individuals in different types of settings?
Right. So we're really happy if we're seeing some kind of effect that on average looks good for everybody, but we also know that's not the end game. We really need to think about how to refine our interventions. And that's why we've been pushing hard on the experimental therapeutics part, because we want to figure out if we've got a target, does it work in all cases for some subgroups, everybody? And it's really important to measure all of those types of steps in the intervention process. So that's why some of those fast acting interventions are going to be interesting because they're by different age groups and they're actually coming out of more translational research that's actually trying to figure out what does change in the brain, actually. We do want to see people thinking about measurement-based care, though, as well. So on the other end of the spectrum, who are the interventions working for? And this is addressing the health equity issue. Who dropped out? Is it the intervention? Is it access to care? Is it perceptions about the intervention? So all of those are still really important things that we would hope our investigators start exploring more.
Okay, thank you. And two related questions. How is NIMH working to address suicide risk among underserved youth? And are there intentional and targeted recruiting efforts for Black male youth in terms of data collection?
I don't know of any specifically right now, but we would really encourage that under that notice of special interest. That would be the exact type of research study we would love to see. So, take a look at that notice of special interest and stay tuned for more things coming out. I think we had a notice of intent to publish with set-asides coming out that also could address that. So I really hope whoever was asking about it can partner with communities where this is a really important issue and we learn more about it.
All right, moving to more of a policy and insurance realm. When considering fast action and response in emergency departments to potential suicide risk, what could insurers do to make this process easier to the extent that you or NIMH move into that area of thinking about this strategically?
Wow. So we don't make determinations about billing. NIMH tries to furnish the research saying what works well. But this is a great example of where partnerships are really important and working with different stakeholders. So we're beginning to talk with different representatives from AMA, and we know some other entities can make decisions about billing and so on. with the emergency room, there's also other issues to consider in terms of you can't turn anybody away regardless of insurance and so on. But we're trying to be aware of all those policy challenges and figure out what research is needed to help make the policies work better.
Okay, thank you. And any insight on self-injury, attempted suicide, or suicide prevention in the underserved population of healthcare workers?
Wow. I think we need a lot more systematic research on our healthcare workers if they're willing to be a part of panels and cohorts, because that's where we've actually begun to learn most about different occupations and their risk. There's, better populations defined. Otherwise, it becomes, surveys where people who choose to respond to something probably elevate the base rate because they're the ones worried about it and are responding. But these are very serious matters. I know Congress is very interested in this topic. And I think we'll be working with CDC, NIMH, people thinking about different occupations. So it's a really important question. And like I said, I think getting good samples, populations that are well-defined will really help us understand this better.
Okay, now going to a specific slide, referring to the slide where you showed suicidal ideation over time in 3 age groups. There seemed to be a seasonal variation between summer and winter. Can you talk about that?
I think that might have been the hospitalization slide. And they did have something about, I think they were picking out January and July, and they were talking about the seasonality of it. And I don't have the paper in front of me to describe it, but if you look at the reference there, you can take a look at that, where they did describe that seasonality.
Okay, thank you. And a couple more coming in about rates. In reference to poisoning rates, could that mean overdoses?
Yes, absolutely. So poisoning includes, prescribed medications, anything that causes a poisoning injury. So it's very possible.
Okay. And then a number of questions about suicide rates in particular subgroups. I'm going to combine some of these, but questions have come in about what data do we have or where can we find it for Hispanic individuals and for Asian youth?
So you can go to the Whiskers and Wonder data sets, depending on the age groups that you select. You might have to look at several years to get the numbers stable enough. And like I was showing you with the Black youth slides, if the number's under 20, it won't even show up. And you can start looking at Hispanic versus non-Hispanic, and sometimes you'll see more racial differences if you don't include Hispanic Blacks, for example. So the data's there. It's, we were accessing it. Anybody can access it if you get on the CDC websites.
Okay. Can we apply technological advances to predict the risk of suicidal behaviors? If the clinicians can do this, then could they expand and other professionals could help with prevention?
So it's a great question because it seems to hold so much promise, but we've been learning over time that you really need that human touch, like a coach, somebody there to help frame what the technology is supposed to be, troubleshoot, help you figure out what it's supposed to, how it's supposed to happen. It's very possible to start task shifting all of that if you've got somebody, but you also might end up with questions that the technology is not exactly fitting. So, we're very happy to support research that begins to look at that some more. So very much welcome those kinds of research ideas.
Okay. And then let me turn to one about underserved populations in general and some of your new funding announcements or initiatives related to disparities. Could you share some of what NIMH priorities are in those areas?
So there's the Office of Health Disparities is probably the best spot to go look for all of these. And there's a number of initiatives that have happened in terms of requesting information, RFIs that have gone out. There's interest in Congress, certainly, about this. We're working on a number of summaries of what we think we know, don't know. And there's also interest across other NIH institutes. So we're combining forces, for example, looking at structural racism. I believe there's an RFI on that right now. So it's a great time, finally, to be focused on this. It definitely is a priority across NIH. So feel free to email me and I'll get you to the right folks is probably the most efficient way to answer this.
All right. And we're out of time. Thank you very much, Dr. Pearson.